very good luck.
Thank you. Until he will present. And who try cryoablation? Okay. So, Prof. Mervat, try, and Dr. Urth, try, Dr. Bradley. What's your opinion about cryoablation? Fair, Dr. Bradley.
I think it's extremely useful in small patients where complication of heart block would be a serious issue, and if the substrate, if it's an accessory pathway near the His or some septal substrate, very, very useful.
Okay, and regarding AF, what's your preferred?
One
patient come to you.
I never ablated AF.
What is the first option?
He's pediatric cardiologist.
Pediatric, no AF.
Okay, so for pediatric, they use the cryo
freezer. We use that so much.
And this is what Muhammad Nada is going to present after you. But I love cryo. It changed my life. I felt that I can do 3 AF cases a day with the help of Mohammed Said, who is professional in this, Mohammed Al-Alfi, who is a big organizer, and Yusuf, who the machine is sometimes has problems, but it works easy.
We use it in parahesian
Of course.
As a freezer caster.
And you will see cases presented. Go ahead, Bayan.
Okay, but as I expect that a lot of attendees not using cryo so much, so I don't present the case. I will present the cryo ablation, okay, and tips and the tricks, okay. عشر دقايق اوكي بس هو اوكي لازم the battery here okay introduction cancer ablation established method for treatment of patients with AF and pulmonary vein isolation is an effective treatment strategy for paroxysmal AF. Okay, pulmonary vein anatomy, pre-procedure imaging, it is the cornerstone of cryoablation. Okay, some operator doesn't rely on it. Okay, 100%, but it is a cornerstone that visualize the pulmonary vein anatomy, give us picture that patient had common vein trunk or no. It's very important and should be every patient before cryoablation we should do pulmonary vein anatomy. Okay, here procedure tips and tricks. Okay, before procedure, what is when I was an operator, okay, and the patient come to me and I asked anesthesia. Okay, what is the important thing that I will tell the anesthetist to do? Okay, the important thing that I don't want muscle relaxant to extend more than 20 or 30 minutes. Okay, it is very important. Why? As in, if I give the patient muscle relaxant in general anesthesia and deep sedation, and especially muscle relaxant, it will affect the phrenic stimulation. So I cannot stimulate phrenic during right superior pulmonary vein isolation. Okay, so better the first thing to ask the anesthesia not to prolong muscle relaxant more than 30 minutes. As Engineer Adil told that we start as a clockwise rotation, we go for left superior pulmonary vein, left inferior pulmonary vein, and that it will take around 20 to 30 minutes. Okay, and then go to right side that we will test the phrenic nerve, so should avoid muscle relaxant, or muscle relaxant effect should be released at this time. Femoral axis. Femoral axis, we have only femoral axis, 2 venous axes. Okay, one for deflectable decapolar caster, to engage the CS, and the other for flex CAS and cryoablation. And we prefer to make the venous axis little bit lower. Okay, as engineer Mohammed told that there is a very big French caster flex cast. So sometimes we take a figure of 8 suture to make hemostasis. So we will do 2 femoral vein axis, one for decapolar caster that we use at the first as in CS, and at the end of procedure, when we start to pace the phrenic nerve, we put it superior vena cava and pace to test the phrenic. Okay? Transeptal axis. What we will do for transeptal axis? Anterior or posterior puncture. Okay? Anterior puncture. Better, little bit anterior. Why? When I go to right side, it will give me space to make to the right side to engage the pulmonary vein, right pulmonary vein. So this for transeptal axis. We can use from transeptal axis fluoro TE guided or ICE guided. Occluding the vein. It looks like easy that we engage the vein with a chief caster and then put the balloon and inject the contrast, but actually it is not an easy. Sometimes it is very difficult to engage the vein, to occlude the vein, especially in a dilated vein. So that pulmonary vein, CT pulmonary angio, it will decide which is better, cryo or RF ablation. Okay? And during technique for this occlusion of the vein, we have a 5 technique. Okay? First technique is the direct approach. Direct approach is the most basic technique that, as you see here, we engage, we cannulate the coronary sinus by a chip and make all aligned in the same direction for the balloon here, and this is straightforward. This is the direct approach. Okay, just inflate the balloon, occlude the vein on the same axis, and most of the cases, when we inject the contrast, it completely occludes the vein. This is the direct approach, the easy one. The hook-sticky approach. What's meant by hook-sticky approach? Like this. Here, we make like hockey stick. The sheath, flex sheath, we engage by a chief caster, and we cannot make it straight or aligned in the same direction. So we make a hockey stick to occlude the vein. And after that injection of contrast, we make sure that we are occluded the vein. Okay, we start to freeze. Third approach, cryoballoon only approach. Cryoballoon only approach, if you see that in previous technique we advance the balloon, the flex sheath to balloon, and in this approach just we make the balloon little bit free. It's not working. هو بيعمل حاجة من عنده. And delayed occlusion approach. Okay, after we engage the vein, we then advance the sheath inside in front of the balloon, and the last approach is trap. Okay, and trap based approach. Okay, and there is some we can do cryoablation also in superior vena cava, but in some circumstances we not used to do this, only in very few patients. Cryoablationdosing through the Achieve mapping caster, we want to achieve time to isolation. And this is an important slide that time to isolation less than 40 seconds and the nadir temperature less than -60, total duration is 180 seconds without bonus. Time to isolate 40 to 60 seconds and the nadir temperature more than -60, total duration 240 seconds without bonus. No time. Okay, okay. Phrenic complication as four slide. No, okay, we have 4 slide complication related to cryoablationphrenic nerve injury, as my colleague said. Esophageal damage in cryoablation is 0.001, and in radiofrequency ablation 10 times more. Pulmonary venous stenosis also it is very less. Okay, and the bronchial damage is 40. Thank you.